Hi there, this is Dr. Leong Hoe Nam from the Rophi Clinic. We're here for another session where we try to make science simple and relevant for everyone. And this time round, I rushed out this video because we found something that may help to prevent long COVID. The video today is actually quite simple. There's some early data to say that the use of oral antiviral may actually help prevent long COVID. This is great news. Honestly, we have little or no idea what long COVID is. If there's any chance of reducing long COVID, this is the way forward. So I'm going to share with you the data and look what's going up ahead. The situation now is this. We know long COVID occurs, but we have little idea what long COVID is. What causes it? Why does it happen? Who gets it? How can we prevent it? What can we do with treatment? How long does it last? What's the prevalence? Well, we think the prevalence is anything between 5 to 15%. And honestly, that's too large a figure. You've seen anyone with long COVID, you do not wish your worst enemies to have it, and you do not wish your own children or your own family have it. It's really, really a dreadful disease. 2 oral drugs have been shown in the effective of treatment of COVID at this point in time. We have the Nirmatrelvir, ritonavir at one arm, and you have the Molnupiravir at the other arm. Do these drugs make a difference for long COVID? Since it can treat COVID, can it in turn reduce down long COVID? Don't know. And we know we're going to get repeated infections. And every time you get repeated infections, you have a risk of getting long COVID again. Done. Someone with long COVID gets COVID, long COVID worsens again. And I've seen stories like this. Or the person was well the first time round but develops long COVID thereafter, and then their entire life is shattered. We need to find something for long COVID. The terms used in this presentation would be things like Nirmatrelvir, ritonavir. And you will know Nirmatrelvir, ritonavir stands for Paxlovid. Paxlovid is a much easier term. I'm going to use it quite often interchangeably between Paxlovid and Nirmatrelvir, ritonavir. There's also Molnupiravir, which is easier to pronounce than the trade name Largivrio. I really have no idea how they come up with such names. Largivrio, which is quite a tongue twister, I prefer Molnupiravir. Very importantly, the term PASC. PASC stands for Post-Acute Sequelae COVID. We also call it long COVID, and I think in the common conversations which we have, we do call it long COVID, but the medical term, they like to call it PASC or Post-Acute Sequelae COVID. There are other terms to describe it: long haul COVID, post-acute COVID, long-term effects of COVID, chronic COVID, whatever. But I think the terms long COVID is something we are very familiar with. But if you're going to read the literature, look out for PASC, post-acute sequelae COVID. This is the study that got me really, really excited. I saw this over the weekend and decided to share this with you urgently and quickly. In essence, it is a study done in USA looking at the US veterans and looked at whether Nirmatrelvir helped in preventing admissions, helped in preventing severe COVID, hospitalizations, and deaths. It makes sense. But they decided to look at something else instead, and this was PASC, which is post-acute sequelae of COVID or long COVID. Did it make a difference? Well, it did. And this is where we're going to dive into the details in a very simple manner. The US Department of Veteran Affairs maintains a large database of all their patients. So you will have all the characteristics of the patients, what medical conditions they have, what did they get admitted for, etc. So it's an ongoing database that's updated daily. So for the administrators, it's an opportunity to have a real life situation, looking at who received Nirmatrelvir, who didn't, and indeed compare with likes and not and something that's similar. So it is a very easy database to tap knowledge on, to get information on. So what they did was they looked at SARS-CoV-2 positive individuals from 1st of March to 30th of June. That's about 4 months worth of data. These were outpatient treatment, and indeed Nirmatrelvir ritonavir was designed for outpatient, and we ought to use more of it outpatient to minimize hospitalization use. They didn't want individuals who had antibodies used. When you use antibodies, you do not know is it because of Nirmatrelvir or is it because of antibodies. It just makes the data cleaner. And of course, in the real life situation, there were people who were vaccinated, unvaccinated, and boosted. So by looking at 3 different groups, you can see if there was any difference. So I think this study is as good as it gets, short of running your own trial, trying to use Nirmatrelvir to try to prevent post-acute sequelae of COVID or long COVID. There were quite a large number of participants, 56,000. I think that's good. That's a good number. On the Nirmatrelvir group, you have 9,217. On the non-COVID treatment group, you have 47,000. Quite a large number. You have a good number of controls, and that way you can try to match them up and make sense of the data. And I can tell you, without going into the details, that there are minimal differences between the 2 groups. Now, you would expect those people on Nirmatrelvir to be sicker, or those with high comorbidities, but if you look into the differences between the 2 groups, they were the same. So there were some individuals who were considered high risk, but they didn't get Nirmatrelvir, which is against of what we physicians like. The more high risk you are, the more likely you should take Nirmatrelvir. I haven't shown you the data between the 2 different groups. Take it from me, they are very similar. There's no difference between the Nirmatrelvir group as well as the control group, the non-COVID treatment group. Then if you look at the number of events of long COVID or PASC in 90 days, and mind you, they use a denominator of 100 persons. In 100 persons with Nirmatrelvir, how many of them developed long COVID? The answer was 7.11, and in the control arm there was 9.43. Immediately you can see there's a absolute risk reduction of about 2.32 per 100 persons. Now 2 reductions of 100, it doesn't seem like a lot, but you think about it, from 9.4 to 7.1, that's almost a 20 to 30% improvement in the risk of getting long COVID. So I do like that. Simplified communications, this is what I would be telling my patients. When you take Paxlovid, you're going to reduce down about 9.3% risk of getting long COVID to 7.11% risk of long COVID. You have 2.32 less cases per 100 individuals. Great. I mean, for a condition where there's no cure, no treatment, no prognosis, any form of reduction helps. And this, to me, is really the beginning, the light at the end of the tunnel. So this slide here looks at the risk reduction in getting long COVID, deaths and hospitalization, and how much reduction there is when you use Nirmatrelvir. So I'm going to go directly into the graph and the picture. You see the dotted line down here, that's 1. The further it is away from 1, that means the more leftward it is pointing on the graph, the greater the risk reduction. So for PSC, you have about 30 to 40% reduction. For deaths, you actually have about 60 to 70% reduction. But mind you, notice there's a long bar. It means a confidence interval. The actual true value might actually be about this range rather than a narrow range. But that's because the number of deaths were actually very few. Hospitalization goes down to about 0.6 to 0.7. Same for deaths or hospitalization, 0.6 to 0.7. So you're talking about a 30 to 40% reduction in risk in deaths or hospitalization. So the clear-cut information here, which everyone needs to take home, is this. If I take Nirmatrelvir, and that's because I have high risk of getting severe COVID, immediately I have an advantage with a 30-40% reduction in risk of getting deaths and hospitalization. And the bonus and the icing on the cake is that you can reduce down the risk of long COVID by about 30 to 40%. Honestly, death, hospitalization are real serious problems. But there's a good chance the doctors can pull you out of it for the hospitalization. For death, well, you died. But for PSC, once you get stricken with such a disease, you can't really get out of it. It's really, really difficult, and doctors are kind of stupid to know how to solve long COVID at this point in time. We need more science. So Nirmatrelvir helps. It moves more to the left. Now, this data here is about the absolute risk reduction. How much does it actually reduce? If you look at the bottom over the x-axis, you're talking about 1 to 2 or even 3% reduction. It isn't a lot. It isn't a lot. The absolute reduction is small, 1 to 3% in terms of deaths, hospitalization, as well as long COVID, but the relative reduction is much, much more. Because the number of cases with PSC, deaths, hospitalization are much fewer. You're talking about 5 to 9 cases. No, really, really small numbers, but the relative reduction is much, much more. So again, absolute reduction is better in the use of Nirmatrelvir. So reminder, if you do fall sick and the option for Nirmatrelvir comes along, take it. It will help you. This is the graph, the same data presented in a different way. You will see that the purple line is the Nirmatrelvir line and the yellow line is actually the control. You do see a difference, and that is a significant advantage. You do notice that even after 40 days, 50 days, 60 days, the line is still diverging, which means that people are still getting long COVID in the arms, in the control arm, but much lower at the rate of Nirmatrelvir. Now, if you look at the y-axis is actually survival probabilities. Is 0.92, 0.961. So the numbers are really very small. The absolute reduction isn't a lot, but it is still a reduction. I couldn't resist but share with you that the data for post-acute deaths, post-acute hospitalization, it does help as well. You might notice that the purple bars, the shading is much wider. It just tells you that the confidence interval is wider. It's not very, very sharp. But nonetheless, the point is this. Taking Nirmatrelvir can help you with death and hospitalization. So by all means, take it if the option comes along and you qualify for the drug. What about Molnupiravir? This is the other oral agent that's suitable for the treatment of COVID. It is by MSD, a different company from Pfizer. It works in a different mechanism. So let's see if Molnupiravir makes any difference. Well, the short answer is that they didn't do a trial. They didn't do a trial on long COVID, but we can glance on other information and try to guess from there. So this is the trial. It is called the UK PANORAMIC trial. A trial actually on Molnupiravir. I say it's a trial because it is actually randomized to look at Molnupiravir versus the best standard of care. And this is done in the United Kingdom. It's randomized. It's a controlled open label platform adaptive trial. It is published. It is accepted. It has been peer reviewed. So this is a much better quality paper because number one, it's been peer reviewed, and number two, you have a randomized trial to it. It is open label, not ideal, but it is as good as it gets in terms of a real life situation. And real life patients like this are a lot more relevant than sometimes what the clinical trial study does. So I like this paper for that. You see the QR code, you can scan and read it. So this UK multi-center open label study started on the 8th of December all the way to April 27, 2022. And they had about 25,000 participants. And honestly, they nicely randomized them into 12,000 each of Molnupiravir plus usual care or just the usual care alone. Okay, at the end of the day, the downer was this. There was no significant reduction in hospitalization or deaths in the Molnupiravir arm. You will ask, why? Well, the situation has changed. When the trial was being run, they were looking at people that were unvaccinated during the Delta situation, where the death rates were much, much higher. But when this trial was running, hitting into Omicron, where the disease was milder, we have less sick patients, so those who require hospitalization deaths, the numbers have come down, and when they did the trial, they did the study, they also accepted vaccinated individuals as well. So it is not exactly the same kettle of fish, or rather the same patients, same group of patients which they are studying. But they didn't show any significant advantage. I think because the magnitude of benefit for Molnupiravir falls behind that of Paxlovid. But it shows you something exciting, and that's why I'm taking you through this paper. This is the exciting part about Molnupiravir. The time to recovery was faster, 4.2 days. So you talk about symptoms recovery, taking Molnupiravir helps you versus not taking Molnupiravir. In other words, if I fell sick and I needed the drug and I take Molnupiravir, I may not reduce down my chance of getting hospitalized or death, but I would reduce down my chance, it will reduce my duration of illness. That means I recover faster. That's exactly what I want. So I'm going to quote in verbatim, in PANORAMIC, Molnupiravir helped to alleviate all of the symptoms measured. This includes fever, cough, fatigue, muscle ache, diarrhea, headache, loss of taste, smell, dizziness, generally feeling unwell. There was a shortened time to self-reported. That's great. It really works in alleviating symptoms, and the person goes back to recovery faster. But this trial didn't address long COVID. I suspect they are looking to the data for it, and I await eagerly for that. So you look at the survival curve, you have the usual care down there in red, but in blue, they will recover much faster. And if you look at the red arrow, it will tell you that the recovery starts changing at about 5 days. Most of my patients will start feeling better at about day 3, but many of them are highly vaccinated individuals. But on this study, you can notice a deviation in the groups at about 5 days of illness. At the 5th day of illness, dose of Molnupiravir starts feeling better. Now, on the stress to you, PANORAMIC trial did not look at long COVID. But if you think about it, with faster symptom relief, you would expect a reduction in long COVID. Because long COVID, most of the time, is actually a persistence of the symptom, a persistence of the fatigue, lassitude, tiredness. If you have fully recovered from this earlier, chances are you will have a lower risk of long COVID. Now, Molnupiravir is one of those drugs where you don't need to worry about drug-to-drug interactions. You don't have to worry about your kidney status, your liver status, etc. You can just take it. And so far, we haven't seen any major problems with long COVID. I've used it on many patients, and they've all turned out to be quite fine. There is a small risk, potential theoretical risk, where it can affect the RNA. This is how Molnupiravir works. Molnupiravir works by messing the RNA of the virus as it replicates. Will it affect the humans? Well, the answer is we haven't seen any conclusive evidence yet. We are concerned, but we have no evidence, and so far everything is fine. Certainly, if you are pregnant, you shouldn't be taking this drug, and after taking this drug, you shouldn't be trying for pregnancy for a while. We do see an improvement in symptoms, and overall, I suspect this PANORAMIC trial will show evidence to say it can reduce down long COVID. What does all this tell you? This is the summary slide. Paxlovid may reduce down long COVID risks. So far, we're talking about a risk reduction from 9.4% to 7.1%. Small absolute magnitude, but high relative risk reduction. So if the option comes along, I would take Paxlovid if I fall sick with COVID. I would immediately have a lower risk of long COVID. And again, long COVID is something you don't wish on your worst enemy. Take Paxlovid if the opportunity comes along. Now, if you can't take Paxlovid for various reasons, take Molnupiravir. Molnupiravir should help because it helps with symptom relief. You're talking about a 4-day advantage. So if I am the employer and my staff has COVID, I would rather they take it so that they can come back to work quicker, faster, back to normal life again. 2.5 years, 3 years of COVID, I've had enough. I'm really quite tired of COVID. This is the end of my slide. Again, same tagline. If you like it, please subscribe, share. Do you have a follow-up question? Ask us. If there's anything interesting which you'd like to look at from an infectious disease point of view, share with us. We'll try to do a video next on it. Again, this is Rophi Clinic, Dr. Leong Hoe Nam. During the YouTube channel, we try to make science simple and relevant for everyone. Meanwhile, stay safe, subscribe and share. Ciao!